Welcome back to Primary Focus. This episode is the last in our series of 4 episodes on Dutch primary care, one of the top primary care systems in the world. In our last 3 episodes, we talked about how general practitioners in the Netherlands ensure their patients have 24/7 access to care through their clinic or in after-hours care centers. And today, we're talking about who or what incentivizes and supports GPs to follow those guidelines. And what happens if they don't? I'm Dr. Tara Kiran, and this is Primary Focus. We're here to reimagine a healthcare system in Canada that works for everyone. First, a quick lesson on how health insurance works in the Netherlands and why it's the key to accountability. And then, Rosemary Hannum, who was actually with me on this trip, will join me to discuss what we think Canada can learn from the Dutch primary care system. If you missed part 1 to 3, now's a great time to go back and get caught up. In our previous episodes on the Netherlands, we talked a lot about the ethos of family doctors, or GPs. When you talk to practice nurses, practice assistants, and GPs, you'll hear them talk about how they feel responsible for offering patients timely care. But they're also actually held accountable for it. Who's holding them accountable? I'd say patients and the public, but also the insurance companies. Now, before you start imagining something more akin to the American system, insurance companies in the Netherlands work a little differently. In fact, insurance companies are one of the reasons that 99% of Dutch people have a family doctor. The Dutch have a unique model of ensuring health coverage for their entire population. All residents are actually required to purchase health insurance from private insurance, and if they don't comply, there are fines. If they can't afford the modest premiums, the governments provide the funds. Most of the financing is public, meaning it comes from taxation, and actually the portion that the Netherlands spends on public care is much higher than we do here in Canada. But I should mention that the insurers are private organizations. The insurers are nothing like private insurers in the US. From what I understand, 9 of the 10 insurers are nonprofit cooperatives, and they're actually all obligated to accept all applicants, regardless of how sick they are. And they have to provide them with a standard insurance package, which is set by the government, and they have to charge all policyholders the same fees. So as you can see, it's a system that's taxation-based, for the most part, and that tries to ensure everybody has access to healthcare. But at the same time, they have some internal competition between these insurance companies who are all vying for members of the population to choose them to have their policy with. Now, access to a general practitioner is part of that standard package. This setup is often referred to as a social health insurance system. It's founded on the principles of social solidarity, just like Medicare in Canada. But in the Dutch model, there's managed market competition between insurance companies who are all vying for patients in the public to have policies with them, and also between the providers that they contract with. I want to introduce you now to one of those insurance companies that Rosemary and I visited when we were in the Netherlands. Rosemary and I are here. Rosemary is with the business school, and you'll hear more about her shortly. Rosemary Hannum, a colleague of mine from the University of Toronto, actually joined me on this trip. At the time, she was the director of the Sandra Rotman Center for Health Sector Strategy at the Rotman School of Management. But soon after, she accepted a new post as a strategic advisor on primary care to Ontario Health. And the insurance company, it's called CZ. It was actually our very first stop on this trip. Rosemary and I got off the plane in Amsterdam in the morning, and by the afternoon, we were in Tilburg. And after a quick lunch, we got on the train for our first interview. We're taking the train from Utrecht to near Eindhoven, where we're going to go be meeting with 2 senior executives from one of the insurance companies in the Netherlands. So we'll be learning more about that system because I think it's pretty foundational to understanding primary care here. This is where Rosemary and I meet Joel and Natalie, two executives from CZ, one of the Netherlands' largest insurers.
My name is Nathalie van Schoonhoven, and I work here for 20 years on the section of primary care, making contracts with the doctors and
healthcare purchasing.
And making policy for new forms of primary care. So everybody has access to healthcare.
I'm Joël Gijzen. I'm now a senior manager, especially for strategic affairs and special accounts.
And it just happens to be a special day in the Netherlands.
Yes. And wonderful to be here on your
You
holiday.
Our first
The birthday of Sinterklaas.
Yeah, it's only
In this series, we've been over a lot of the cultural differences and similarities between Canada and the Netherlands. But this was one I wasn't expecting.
It's the birthday of Santa Claus. That's what it is?
Not Santa Claus. We know Sinterklaas, and we also have Santa Claus. Santa Claus with Christmas.
There's two different people.
Sinterklaas is mainly for the children. It's from the Middle East, and a fairy that a bishop of the south comes and gives presents to the children. And afterwards, we have Santa Claus, Christmas. That's 2 weeks later.
So the little children mostly get their gift from Sinterklaas and not from Santa Claus.
Oh, really?
I guess I should have read up on Christmas traditions in the Netherlands.
Thank you so much for reading.
My children.
Joel and Natalie, in true Christmas spirit, were more than happy to host us in the middle of the holiday season nonetheless. Okay, back to CZ. Insurance companies like CZ are actually obligated to find their customers' GPs.
There's national legislation that we have as a private company have the obligation to provide our customers, our clients, from enough primary healthcare, secondary healthcare.
And are there specific standards that are in the legislation,
Yes.
To define enough?
Enough. It's very different per sector. In the hospital care, it's other standards than in the primary care.
Yeah. For the primary care, it means that you are a family doctor. We call it een huisarts. That all our people can be do have a family doctor.
Yeah.
So, like a family doctor in the Netherlands has about between 2,000 and 3,000 patients. And when they say we are closed, we cannot take any other patients, we have a problem.
To fulfill that obligation, insurers like CZ, they contract with GP owners or practices to provide care for their customers. The contract specifies the payment and obligations. Insurers carefully monitor their list of customers to ensure everybody has a GP. And like Natalie says, if they can't find everyone a GP, they have a problem. And they're on top of that problem.
Is there a central registry of every person and their family doctor?
Yeah.
And does that rest with the insurance company or with the government? Or
We can. It's an independent organization, and we can check. So we can check every first of a quarter. We check are they registered by that kind of doctor.
But the registration happens with the own insurance company.
I see. So they're registered with you,
Yeah.
and you tell
and
them.
we tell it to the UN.
Mr. Smith has Dr. Jones.
Yeah.
And then
A large part of the incomes of a general practitioner and family doctor is done by an abonnement. We have to call it abonnement.
subscription?
Yes, subscription. I have in the translation. Yeah. So
like
a family doctor gets a subscription pro registered patient from us.
And what percentage of their
income? It's like 75% of their income is from that kind of...
It's a fixed fee, is that?
Yeah.
Per
fee.
quarter.
In this capitation model, payments to GPs is based on the age of the patients in their roster, as well as the deprivation level of the neighborhood the patient lives in. GP's remaining income is largely fee-for-service or pay by the visit, and this model is really predicated on each GP being responsible for about 2,300 patients. The standard pay they get for that panel of 2,300 is supposed to be adequate to cover average practice costs, including rent, IT, office staff. GPs can ask for additional resources from insurance providers for managing chronic conditions and specific unmet needs in their community. Interestingly, the GP fee rates are set nationally based on independent assessment of GP practice costs done by the National Healthcare Institute. There's actually no negotiation between government and the medical association.
Yeah, the fees are not a result of negotiation, but a result of cost pricing investigations. And then based on the cost price investigations of the National Health Institute, they make tariffs.
All of the things in Canada, it's all negotiation.
Yeah,
Okay. So we are
not,
just processing this. Okay.
So
is
German-
there lobbying?
Cost,
Like,
price.
There is, of course, though, a physician association that lobbies to change that. But Joel says so far it's not been very successful.
The National Health Insurance Institute has also an obligation to make transparent on what basis they make tariffs, and there's no room for changes about negotiations.
interesting. Okay.
That is really interesting.
This is
So
helpful.
just to understand again, so this National Health Insurance Institute, can you just describe again how they set the price? You said that it's a cost price investigation.
Yeah.
What do you mean by
They
that?
go to general practitioners.
Yeah.
They ask, let me see your household
rent.
book,
I see.
all your cost drivers in your practice. They do that with 10 or 100 general practitioners. And they distillate a general price model from that investigations.
Joel says the contracts specify care that must be to the standards developed by the Dutch College of GPs. There are also national standards on acceptable wait times for non-urgent care called trijknorm, which the insurance companies monitor.
Now we refer always to the trig norm. That is it was placed in the Netherlands, where in the end of the 80s of the former century, people of the total healthcare sit together, patients, government, insurers, and they define there what are standards of accessibility of the healthcare.
Oh, wow.
And
Okay.
that place was called a Treek. There was a village that called Treek.
Oh, that's the name of the
And
village.
since the end
Got
of the
it.
80s, the Treeknormen are zeg maar, the basis of the contracts that we have with the health suppliers that we contract, but also in the policies to our customers. There are also
there.
Yes, when they have a heart cardiologist they need, and they must wait longer than what the trach norm is, they can go to a judge, and the judge says to us, "Van, you have to provide within a specified time limit healthcare."
And here's where that accountability piece comes in. If customers complain that they can't get timely care, the insurer investigates, provides warnings, and eventually they have the power to end the GP contract if necessary.
And then they're purchasing when they come to you.
What would the judge do if they complained?
They can give us an arrest. We can a penalty, a fine. Yeah.
As the insurance company, you're watching carefully
Yeah.
to make sure your contracted providers are meeting those standards.
Yeah.
A note here that Joel says patients making formal complaints to a judge is actually quite rare. It's clear to me that this system is very customer-oriented. It's a key ingredient that I've noted is shared with many high-performing health systems in the world, like in Denmark or in the Nuka model in Alaska. And honestly, I feel like it's something we need more of in Canada. There are many checks and balances in the system, including many options for patients to voice their dissatisfaction. For example, if they routinely can't get a timely appointment, they could voice their dissatisfaction by speaking directly to the GP. They could contact the complaints officer associated with the practice. That's an affiliation required for GPs. They could approach the disputes committee, another required affiliation for GPs, or at the most extreme, hold the GP accountable through disciplinary law. If there are a lot of complaints about the quality of care, a practice may also get investigated by the insurer contracting care or by the National Health and Youth Care Inspectorate responsible for quality and safety. But these checks and balances are tools that are not needed for the vast majority of practices. From speaking with several GPs, it seems to me that providing timely care is just part of the professional ethos of GPs in the Netherlands. My trip to the Netherlands was eye-opening for me. It was amazing to see how differently things were done, and this conversation with Joel and Natalie really laid the groundwork for so much. As a physician and a health systems researcher, I really bring a specific perspective, though, to understanding the system. And what I loved about having Rosemary on the trip with me is that she was able to apply her business school lens and had a slightly different kind of perspective that she was seeing things through. And so that's why I wanted to have Rosemary join me in conversation for this episode. Rosemary Hannum, welcome to Primary Focus. I'd love to hear your reflections, Rosemary, on our trip. It's been, almost 6 months since we went, and now you're steeped into primary care reform here. What are some of your reflections from your time away? What stuck with you?
Oh, such a great question. I have many reflections from that trip. It's really stayed with me, the different people that I met and the different places I visited, and how well organized and well run their system is. My first thought is how happy everybody was in their work and how much time they had for us, Tara. We were really just so privileged to be able to speak to them, and they had time and really wanted to show us their experience and what they loved about their work and the patients they see and the care they give. So that's really stayed with me as something I think we are striving towards in Ontario. Like, what would it take to set up the same environment and to have the same reaction if we were to go into a primary care practice here? And so I think that was sort of a bit of a guiding light in my questions and in my approach when we were speaking to different groups and people about their work. And I think the other thing that really stuck with me was how they just didn't even question access. So they just assumed that they needed to be available for their patients always. And they had to keep a good work-life balance, but they spent a lot of time thinking about how best to organize themselves so that anyone who needed care would have care quickly. And that just was so consistent. And when we asked about, how do you maintain those standards and make sure that everybody's creating and making that access happen on a day-to-day basis, there wasn't too much that anybody pointed to. It was really just part of the culture that you would be available for your patients. The other thing that really stuck with me was the students and the residents are happy in their choice. I mean, I guess we were meeting those that had chosen family medicine, but they were really eager to start their careers and had thought about different options for themselves and just had a lot of great positive energy. And that was neat to see as well. And there was several that I met that had been in specialties and had decided to end their residencies in a specialty and come into family medicine. And we're really glad about their choice.
I think all of the things you said resonate. It was a lovely group of residents that we met. And I think it was also interesting, Rosemary, that the majority of those residents were actually doing their residency part-time, which is a very common thing in the Netherlands. And I had to wonder, is that part of the reason maybe why they were all so happier? They were working basically 4 days a week, I think, in general. That decision for balancing work and family, because some of them were also older and already had children. So that just seemed like such a reasonable thing to do that we don't really allow residents to do here. And I also really loved how in their training, they had a real focus on understanding themselves and what they were bringing to the relationship that they had with patients in order for them to be the best doctor that they could be. Understanding that they really needed to understand themselves first and the kinds of perspectives, I guess, that they were bringing to that relationship based on their own life history and experiences. I think they talked about this day that they would have together that they called crying in the woods, because they would all share with each other like the, deepest kind of feelings and pieces from their own history that shaped who they were, that were sometimes very emotional, but are an important part of, I think, being a really open and communicative and empathic clinician.
Yes, that stood out for me as well. And in addition to helping them understand how their own personal experience would influence the way they were as clinicians, it also had this career focus, and maybe that's not the right word, but it was done with an understanding that this was a role you were going to have over a long period of time.
Mm-hmm.
And
right.
that
so they didn't want you to burn out.
Yeah, they didn't want you to burn out, and they wanted you to be setting up ways for you to support yourself as you entered practice on a day-to-day basis, and went into the weeds a little bit, which I was kind of surprised about. But they said, we talk about how you need to have community within your practice, how you need to be meeting regularly together and socializing and having breaks together and lunch or coffee. And then when I went to visit practices, and I noticed in your experience, I think it was similar, and I also interviewed a couple of family physicians, they all did that. So it was striking how consistent it was. Like, they all come together half an hour before they start seeing patients, and they have coffee together in the morning. They all seem to find a way to eat something together, just even for half an hour in their communal lunch area. And then they end the day together.
Of course, there's the community, there's the food, the socialization, but also this concept that you said that they just seemed happy. And I actually had a great conversation with some GPs at one of the offices that I shadowed. This was the office with Yeti Bonte in Amsterdam. But I wanted to play this clip, Rosemary, because they were actually talking about how there was an article in the BMJ talking about how Dutch doctors are happier. And they were like trying to explain, like, why is that?
But I think there's also a strong, we mentioned culture and tradition, that the GP in the Netherlands is like a key figure. And there was, I think, once a paper in the BMJ about comparison between UK and the Netherlands. Why are the Dutch GPs so much happier?
Oh.
It's an interesting paper. And one of them is really the representation. And I think the GP now is already less prominent than it used to be, because they were even doing obstetrics. I mean, when there was an issue, you went to the GP. So the GP, it was your first contact, and not the hospitals. Your GP, and then GP, so for example, in the Netherlands, the GP is much more respected than the emergency department specialist, which is only like 15 years now and is still struggling to get an identity. Whereas the GP is very clear, and we've got our own guidelines. We don't have like nice guidelines of everything. We have representation like the LAV. It's very clear.
So I think part of that GP's reflection, it seems to me, is that it's also the status and the view of the GP and the clear defined role, not just of the GP as a professional group among GPs, but also the way that they're perceived by the public as really the central point and central figure. I think they have a history of being very respected, and it sounds like that's maybe also a reason why GPs are happier in their jobs. I think this physician also touched on what you touched on, Rosemary, which was this idea of access just being part of what they do. So they talked about GPs were the first point of contact for everything. And of course, if you have to be the first point of contact, you have to have this ethos related to access. And, I think in our previous episodes, we've explored kind of what are the practice organizational pieces that enable GPs to do this. But I wanted to ask you, do you feel that there are health system elements that also motivate and support GPs to deliver timely access?
Yeah, I do think that the ethos is supported by the contractual obligations, which the insurance companies include in their contracts, and then there is a system of enforcement. In my conversations with the GPs, they know the expectations of access, which are very clear and listed in this intriguing website, which lists access guidelines and standards for all specialties, including GPs. And they specifically note how long it should be until a patient can get an appointment. And it should be no longer than 3 days, but ideally 2 days. They say that the phone needs to be answered if it's an emergency within 30 seconds.
Wow.
Yes. And it's listed right there. So during office hours, the practices have to answer calls within 2 minutes. And for urgent situations, they must respond within 30 seconds.
And I mean, I think it does go back to all of the elements that GPs have integrated into their office, like the practice assistant, but also to your point, the ethos that GPs have around access. This is again from that conversation that I had with Yeti and her colleagues at her practice. And I think it speaks to this ethos.
I think it's part of the tradition of general practice in the Netherlands as well, because I think acute medical care is really part of GP practice in the Netherlands as well. So we even have like, I'm not sure if you heard this kaderartsen development as well. It's like GPs specializing in a certain area. And one of the specializations is also acute medical care. So I think that acute medical care is really considered a key element of general practice in the Netherlands. So because of that, we have like every day there are urgent spots available. So we tend to look at our day staff that's being present on a day, and we make sure that there are at least a couple of appointments available for acute questions.
And also, I think we have in our re-registration to hold our license, we have to work a certain amount of hours during out-of-hour service.
Mm-hmm.
We have to.
I heard that. Yeah, that's about
Every
like
GP.
One of the
about 10 shifts or something like that, right?
Something like
Yeah.
that.
Yeah.
So it's one of the 3 issues that you need to. So when you want to reapply after 5 years, you have to prolong your registration. You have to work in out-of-hours primary care. You need to work in a GP practice, and you need to do some education. So that's those 3 points. So it's really part of the tradition, I think, I would say.
I really like that system of everyone having to do that after-hours care. It is an interesting mechanism for not only ensuring there's availability of practitioners, but the exposure to other professionals and teams and experiencing more acute types of incidents is also beneficial.
And I think both you and I also remarked to each other when we were there and since then how remarkably uniform the way the practices were in terms of their organization. So they, there's GPs, there's like a somatic nurse, a mental health nurse, practice assistants, and those are really the core team members in the practice. And, the nurses generally had a very standard role, even from practice to practice. And yeah, I'm really interested in your thoughts about how is it that things are so standardized from practice to practice in the Netherlands compared to, here we are in Ontario, and it's actually very heterogeneous. Like the role a nurse might play in one practice might be completely different than another. And the team members in one practice might be completely different than the other. Of course, that's in practices that even are lucky enough to have funding for teams. So what were your reflections on why there was that standardization?
Well, it's not that complicated. I would say the reason is the GP contracts are all the same. And throughout the Netherlands, there's one contract. You can Google it, download it. And it includes a certain set of professionals. So it's for one practice physician and 1 or 2 nurses, plus the practice assistant, plus there's some time allowed for a practice manager and a second office assistant role. So I think maybe 5 different roles in total, and it can be sort of scaled up a bit or scaled down, but it's quite uniform. And there's some complaints about that and frustrations in the Netherlands because there's different places that you practice, and it would be nice to be able to have a bit of flexibility.
I think one of the things that I thought was striking was also the Dutch College of GPs, because the Dutch College of GPs really, they provide these guidelines for GPs by GPs. And these guidelines that produced by the Dutch College of GPs seem to be like the foundation for a lot of things, whether that be the way that triage is done or the chronic condition guidelines or even, what prescriptions you might use. And it's like this very strong tradition of doing that. We were there together, Rosemary, and we talked to Rob Jishka, I think was his name, the former head of the college. So a few nice clips actually from our conversation, and they talked about how they were the central piece. But yeah, how does it work? Like, tell us.
It's good to know. I was the president of the Dutch College for 6 years, up till 2019.
Okay.
And in that time, indeed, there was already a lot of those GP guidelines, starting from 1989, when the first guideline on diabetes was made.
1989.
Yeah.
Okay.
And then we had about over 100 of the GB guidelines by now, followed by a number of small guidelines on small subjects. So there's a broad set of information. And the way that we work is that we make those guidelines, they're made for and by GPs, but always in concordance with the medical specialists. So if you have an ETN subject, there's always an ETN surgeon involved.
Yeah.
And that helps to make the connection not only on knowledge, but also on connection to secondary care.
It's GPs leading GPs.
Exactly. Yeah.
And I think there's a strong culture and organizations also that actually support that, and that they've developed these over time, and a longstanding tradition really of that kind of approach. The other thing that I thought like related to the Dutch College of GPs that was really interesting was their award-winning patient website, which really empowers patients to be able to take care of minor ailments at home themselves. I had a really interesting conversation too, back and forth about how, in Canada, when their patients may have a minor ailment, we've now said, oh, you can go see a pharmacist. And sometimes that minor ailment, to be honest, doesn't require any medication, like in the case of conjunctivitis. And I think when I was talking to the Dutch colleagues about this, they were like shocked. Like, how is it that you're paying a pharmacist who has obviously a financial incentive in selling some kind of antibacterial treatment? How is it that you're paying them to treat something that actually requires no treatment most of the time? And in their setting, I think patient who has conjunctivitis, like they would be getting all this information from the patient website. And I think it really speaks also to that. So first of all, to the GPs leading, and they developed this website based on the Dutch College guidelines. But then, this idea of patient empowerment, I feel, and patient choice, and the way, it's citizen-centered, it's person-centered, their whole system.
Agreed. I think we could do a whole episode on this. I think because they really do believe that the patient should be leading their own care and responsible. And so this website is there to help enable that and help them learn. Also really encouraging and reinforcing of the fact that, you should be in charge and responsible for your own care. And also then as a parallel, you have access to your medical records.
Yeah, agree. I know you mentioned that you prepared some notes for today, and you had some things that you wanted to share too. So I wanted to make sure that you had time. Were there things that we haven't talked about yet that you wanted to bring up, Rosemary?
Yeah, a couple of things. And I guess they fall under the interesting system elements that I thought were really striking in the Netherlands that we haven't talked about yet. While we did talk about the patient owning their own care, I think there is also in the Netherlands a feeling that the state needs to make sure that everybody has a family doctor. So the insurance companies have the responsibility of making sure that everyone who comes to them and registers as a patient has access to care. And that is a very real responsibility. And if you are not able to find a family doctor and you're registered with the insurance company, you call them, they find you someone and they make sure you've got care. And that was very impressive to me. Each insurance company spends a lot of time thinking about how many practices need to be up and running in this catchment area so that all people are covered and can access in a timely way. And so they have a lot of systems in place to measure that. So that to me, I thought was a very critical system element that we do have notionally in Ontario, but we don't actually have in practice.
Well, I would say technically it should be the government here who is the insurer, right?
Yes, that's right.
And so either the health authority or health agency or the Ministry of Health itself, depending on the province or territory. But I think what you're speaking to is that, you know, there's ongoing planning and monitoring about the supply of GPs and primary care relative to the demand, and they're using data to do all of that, and that the insurance companies take it on themselves to do that. And probably the government is also doing that in conjunction with the insurance companies because, you know, it's the government probably making decisions about how many people to train and where to train them, etc. So I suspect there's some partnerships there, but it's clear that there's accountability for being able to deliver on that. And I think what's happened here is, you know, you might have a service like Healthcare Connect in Ontario, and there's similar services across the country, which technically are supposed to be like, you call that place and that place is supposed to get you a family doctor. But we've just kind of accepted like that could be non-functional and you might need to be on a wait list for like 10 years to get one.
We don't, yes. So we have the function and I guess we have the accountabilities, but it isn't active.
Well, we technically have people who should be responsible, but it's not clear that the mechanisms are in place or that everyone feels that they really are responsible. But I think just like as we close up this conversation, Rosemary, I actually wanted to play you one last clip. And this was a clip actually of someone in the audience when I was giving a presentation. They, following my presentation, asked this question. They said to me, Canada, it seems like you're a warning for where it is that we could end up in the Dutch system, you know, if we're not careful and we don't invest and continue to support primary care the way it is.
And I think we all were shocked by the numbers that you presented, right? And I think one of your participants called it a crisis, and I think that's very accurate. It's a crisis, right?
It is. It is an accurate word.
Right. But then the arguments that you provide are things that I hear, well, the arguments that I hear here as well, they sound very familiar. So I'm wondering, from your perspective, could this crisis have been prevented?
Yes.
And at what point?
I do think, I mean, as I mentioned, like I've been doing research in this area for 15 years. My colleagues have been doing it for longer than that.
Yeah.
And some of the things that we continue to say today are things that we said 15 years ago. And I think one of the things, there are many decisions that have been made over the years too that I think are have led us to where we are. One example of those decisions was that we cut medical school enrollment and residency training in the 1990s. And so that reduced our workforce supply, and we never caught up. And so government really needs to do more health human resource planning. And I think people were also very slow to look at the trends because GPs today work less than they did 30 years ago. I mean, that's a trend that could have been seen and identified. That is basically the case for everybody in the workforce. Nobody wants to work 80 hours anymore in any profession. And almost everyone works in a family where both people work. So it's a very different context now than it was 30, 40 years ago. So I think there were ways in which we could have predicted where we are today. It's too late for that. But yeah, what were the things that you thought were shocking?
So in here, we're having conversations about how to have access to your usual provider, right? Rather than access to primary care at all.
Yeah.
Right. So that's a different perspective. And we're really focused on a particular provider now. Whereas I think that we should go to more team-based solutions. But it sounds to me as if in Canada, it's also access in the first place, right?
Yes, it is.
Any access to
access. So I think what you're saying is you're trying to improve the system even further, but everyone has access here to something.
Yeah.
I had similar experiences in my conversations in the Netherlands where I actually felt people were holding back from sharing their true feelings of shock and almost like, how could we be so irresponsible? How could we be letting this happen? Aren't we a modern, society that talks about this publicly funded healthcare system that we have, and yet allow this? And it was I could catch it in people's eyes, almost like a real like criticism coming through, like, what is going on with you guys?
And I think, to your point, I think it's very unexpected too for people, because they think of us as having Medicare and having a tax-funded healthcare system that's universal.
Yes, exactly. Universal. And it was akin to not educating your kids, something like that. Like, that was how grave they thought the situation was. And so much so that the conversation didn't go too much further because they didn't know what to do with this information. That's how it felt to me. So for me, it was very sobering, because I think even I, after a while, the numbers kind of become numbers and you forget that there are people, and it's being not a clinician and not actually seeing the real life examples of what this means for people if they don't have access to primary care. It maybe wasn't quite as sharp as an issue, but after speaking with my Dutch friends and others that we encountered, I realized, oh my goodness, like, wow, we have a lot of work to do. And that was very motivating in that way, but also kind of really hit me. How could we be so complacent? I feel like there's a
That's exactly the word that was coming to mind, is that I think as a society, we've almost become complacent that this status quo is actually okay. And it's almost like when you go to another country and realize the status quo is far, far from okay, right? And you see it through their eyes. I mean, I will say, talking to people across Canada over the last few years, I have,
yes,
it has been clear to me that it's not okay. But I don't know if it's as clear to everyone. If you're one of the lucky few to have care, maybe you don't realize how bad it is when people don't. I don't know. Or maybe we just accept that it can't be any better. Sometimes I think it's that, actually, that we accept that it can't be any better.
I think so too. And that's something else that I thought was so valuable about going to the Netherlands, because you see it better. So all the things they have, we can do. It's just choices we've made that have led to this situation. It is not a given that a system needs to be the way ours is. And that, I think, often gets lost too. We just sort of accept things because, well, that's just the way it is, or we don't have enough resources, or we don't have enough physicians, or we have a lot of rural space, and there's just not enough people. And that might be true, but also it's true that we are organized and structured in such a way as to have allowed, and I think, the system to evolve into this state we're in now. We hope. Our system is hope. We graduate all the physicians, and they choose the residency they choose. We train them, but then at the end of the residency, like, it's just up to them to decide how they spend their days. And that is just completely the opposite in the Netherlands. They have the positions that the physicians step into all set out through these contracts that they have enough of to cover everybody. So there's a plan. So anyway, we could talk a lot about that.
We could, yeah. No, it is a stark contrast. And so just as we wrap up, is there anything else you wanted to share, Rosemary, that I didn't ask you about?
I want to repeat the opening comments I made about how impressed I was with how happy everyone was in their work in primary care, how valued they felt, how much they enjoyed being part of their patients' lives, and how rewarding that was over their full career. And it wasn't like, it was a real calling for them to be in this position. And I think all of that we can do too.
Yeah, so I think lots that we can take away, but I guess one of the things you've emphasized today is almost like the outcome that we should be looking towards there, that it is very possible for us to have coverage of everybody while still having a very happy workforce that enjoys going to work every day and caring for their patients. And I think, an empowered public is part of that story too. I think we reflected on that. And a profession that is self-governing can contribute highly to that as well, in the context of people in that profession working together, not just in their practice, but in their community to serve the community. I think those are all themes that we touched on today and that have, stayed with me as well. So this was such a great conversation because it also was able to bring me back to December. And it's been really nice to check in about my own takeaways and my own impressions about what the Dutch system was like with you. It was such a joy to speak with you today, and it was a real pleasure to travel with you too.
Yes, it really was. Well, my feelings exactly. Very nice to reflect with you.
Well, that's a wrap on our 4-part series on the Netherlands, a country we can learn a lot from when it comes to primary care. Huge thanks to the many Dutch people who took the time out of their day to meet with me and teach me about their system. Special thanks to my hosts Tim Oldhartman, Suzanne Lithgow, Eric Molvan-Charant, Ralph Harskamp, Jetty Bonte, Bart Nottenurus, and Joel Giesen. They all helped me with my itinerary and even answered questions for me when I was back in Canada. Thank you to Rosemary Hannum for her help fact-checking these episodes, and a massive thank you to my producer, Avery Moore-Kloss, whose creative skill brought our audio documentaries to life. I was a total newbie when we started this journey, and she did everything from lending me a field recorder, teaching me what audio to collect, to listening to dozens of hours of tape to help us figure out what story to tell and how to tell it. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by a grant from the St. Michael's Foundation. Miriam Dinesh is our research assistant, Seema Marwaha and Emily Holton are creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.